afternoon, and good morning for those on the West Coast. For those of us joining, I will get started in a moment. We are letting everyone join in, but good afternoon and good morning for those on the West Coast. Okay, we'll go ahead and get started. But good afternoon, good morning for those on the West Coast. Thank you for joining us for our Coordinated Specialty Care for First Episode Psychosis, Cost and Financing Strategies webinar today. We'll be going through a few logistical items before we get started. If you have any technical difficulties, please message Kat Katamara or Jessica Robbins, and they will assist you. For any questions you may have, please feel free to enter them in the Q&A box, and the panelists will answer your questions throughout. The chat is also available for further participant engagement throughout the presentation, and we will be sending out the recording and slides as well. So please be sure to be on the lookout for materials after the webinar. Thank you, and I will turn this over to Howard Goldman. Thank you.
Thanks, Dominique. It's my pleasure to serve as moderator today for this webinar. I'm Howard Goldman. I'm a professor of psychiatry at the University of Maryland School of Medicine and an in-house consultant to WestStat, a member of the managing team for the Center for Financing Reform and Innovation, which is the contract from SAMHSA that developed this work. I wanted to give a praise and acknowledgement to Asha Stanley, who served as the project lead from SAMHSA, and to Jennifer Caputo, who is the task lead from WestStat. We have a pretty simple and straightforward outline for our webinar today. You can see it on the second slide. We can advance that. It's really a sandwich of opening remarks and closing remarks, including a review of the report that was developed under this contract. There'll be a panel conversation, and then if we have time, we'll have some questions and answers between the audience and our panelists. Really pleased that so many people were interested in this webinar, and without taking any further time from our short agenda, I want to introduce our opening remarks speaker, Anita Everett, who's a colleague and friend. She's the director of the Center for Mental Health Services within SAMHSA. Previously, she served as the medical advisor to SAMHSA. She's worked in state government. Not that long ago, I visited her coordinated specialty care programs in East Baltimore when she was the section chief for the Bayview Community and General Psychiatry program and was on the faculty of the Department of Psychiatry as well as the Public Health School. Dr. Everett is a champion for behavioral health services She served as the president of the American Psychiatric Association, and she wants to talk to us today to kick off our webinar on first episode psychosis services in coordinated specialty care. Anita?
Wonderful. So thank you very much, Dr. Goldman. Thank you for that introduction. It gave a little more context than was necessary, but I do appreciate it tremendously. So thank you. And I as well have enjoyed a long-standing relationship and appreciation for your work and the contributions you've made to the whole landscape of public mental health services. So we're here today to talk about coordinated specialty care, which, as many of us are aware, is a multi-component, team-based and also evidence-based early intervention service for individuals experiencing a first episode of psychosis. The federal government has been interested in coordinated specialty care because of its value and life-changing at a time of development that is critical, absolutely critical, to keep, when these illnesses, major mental illnesses first come out, to do whatever we can to help individuals track into what as close as possible to what would have been their trajectory, and not to sort of drop out of life, drop off their trajectory, to do well and learn how to work with the situation at hand with the illness that's present. Back in 2008, the NIH launched a study that was called RAISE, Recovery After an Initial Episode of Schizophrenia, to test and implement this model. The RAISE showed that the coordinated specialty care improves the quality of life, social and clinical outcomes for individuals with first episode psychosis, and can in fact reduce the duration of untreated psychosis, which seems to be part of the special sauce of getting these individuals into treatment and back on their life trajectory. Subsequent studies worked on the implementation factors that related to the coordinated specialty care and demonstrated that, yes, it could be implemented with fidelity. Since 2014, in and around that era, Congress passed, enacted funding for SAMHSA that tagged first episode psychosis funding, dedicated funding to every state through our block grant program. And so now we're at a situation where every state has a certain percentage of its block grant that it's to exclusively dedicate to coordinated specialty care development and maintenance. So we've been through a time of having very few programs that we could identify to now nationally having over 400 coordinated specialty care programs. It is, in fact, my favorite policy story with regards to scaling up of services and bringing evidence to practice. So we've done really well with that. When the mental health block grant funds were first provided to states, there was an emphasis that states should help programs work on the sustainment work on plans, to sustain the programs. And as we have learned in the several years, 7 to 8 years or so since we've had this set aside, some states are able to do that, but many states are not. And there are many reasons for that, which we're going to explore in detail in this seminar today. The NIH has estimated that over 100,000 individuals per year could benefit from these programs, and we serve a small percentage of those. So what we want to do is create capacity by having services that meet the standards, conform to the criterion, are able to bill and thrive financially so that they are sustainable in that way. And that's really what the thrust of this is all about. Then that was information that was based in a report that was created through this CFRI contract, as Howard mentioned earlier. And that is really what we're here today to talk about. This report details sources of sustainable funding so that states can take advantage of a wider array of financing approaches, allowing them to first implement coordinated specialty care, which many times does involve money from the block grant, and also to sustain them. So thank you very much for that. And let's see, do I turn back over to you, Howard?
Yeah, just over to me. Thanks a lot, Dr. Everett. Anita, it was great you reviewed that history of the development. I agree with you about the importance of it as an example of implementation. And it's really striking. The NIH has it listed on its special programs of consequence and bringing evidence to practice. So they've echoed your own remarks. Now we're going to turn our attention to the report findings. I want to call your attention, if you're seeing the same screen I am, there is a URL for accessing the report that's available now. We're going to hear from David Shern as a reporter and reviewing the report findings. Many of you know Dave Shern. From 2006 to 2012. He was the president and CEO of Mental Health America, leading advocacy group. In 2012, he left MHA and went to the state mental health program directors as a senior public policy and public health advisor. He holds appointments at Hopkins. And in the past, before he went into advocacy directly, he was the professor and dean of the Florida Mental Health Institute. He and I have worked together on research and policy issues for about 35 years. He'll go over the report findings for us now. Dave?
There we go. Yeah,
I was on mute.
I was muted. That's that's got to be the phrase
of the watchword of our pandemic life.
Right, the phrase of the century. And Anita did just a terrific job in terms of teeing up the issues. Can we have the first slide, please? I think for everyone's sort of benefit, it's important to realize that psychosis can be a very serious and disabling condition that's generally characterized by loss of contact with reality, and that the first episode of psychosis obviously is the first time that the persons who develop these conditions experience psychosis. And harking back to that Mental Health America stint, actually after I left, one of the major moves in Mental Health America was before stage 4. And the notion was that in the serious mental illnesses, oftentimes our interventions occur at what would be the equivalent of stage 4 cancer. And Anita talked a little bit about the disablement that's associated with these conditions. And the whole goal here is moving upstream and getting to people earlier. Next slide, please. Anita also characterized coordinated specialty care nicely. Here you can see sort of the 5 core services that comprise coordinated specialty care. But it's important to note, and this also relates to the shortening duration of untreated psychosis, that one of the core components, and one that can be difficult to cover from a fee-for-service perspective, is community outreach and engagement and public education. Because in order to shorten that duration of psychosis, it's really important that all the places that persons may encounter when they're ill be aware of these programming and get people hooked up very quickly. Next slide, please. She also mentioned the RAISE study, and the RAISE study is one actually of several that have looked at the outcomes associated with these conditions. And as you can see here, and as Anita, I think, highlighted, is that they're effective in terms of reducing symptoms, psychiatric symptoms generally, improving quality of life, importantly, including education and employment outcomes, 2 things which characterize difficulties that persons who have untreated psychosis often experience. Next slide, please. Anita also talked about the fact that these programs grew from 2014 on. And as you can see, in 2017, after the block grant funding kicked in, there was a dramatic, we had earlier, you would see that originally there were like 14 or 15 programs in the country. This starts in 2017 after the block grant. And then you can see over several years, the number of programs has increased to over 400. But she also noted that although that's very impressive, that does not give us population coverage. And in order for us to meet the needs of the population, we need financing mechanisms that can both support the development of the program and their ongoing operation. Next slide, please. These are actually, from my perspective, very affordable programs. And what we have here are cost estimates derived in several states and associated with the RAISE intervention as well. And you can see that the inflation-adjusted estimates turn out to be about less than $1,700 or about $1,700 a month. I used the $1,650 and estimated that results in an annual expenditure of about $20,000. These programs vary, but often they're intended to be for about 2 years to keep people sort of on track and not becoming dependent on the mental health system. And so that would be about $40,000 for an episode of care. And let's just compare that with a shoulder replacement or a knee replacement or any surgical procedure, for example, that we would think could not, we wouldn't have a second thought about spending that amount of money. And so these are very, from my perspective, very affordable interventions. Next slide, please. Additionally, Many of the studies that are summarized in the report demonstrate a cost offset, so that not only do we get improved outcomes, and our hope is that those outcomes will be lifelong and incur lifelong savings, both in terms of utilization of services, but also in terms of the human capital that people represent and the contributions that they can make to their communities. We summarized 15 studies, and 14 of the 15 that we summarized showed that, in fact, these programs save money. They reduce hospitalization, emergency department visits, improve quality of life. We also have some other data that indicates that they reduce contact with the legal system, which we know is also very important. Next slide, please. Anita also talked about the fact that the mental health block grant has been extremely important in terms of the development of these programs nationally. And additionally, there are Medicaid sources that can be used to cover some of the CSC service, and we'll talk a little bit more about that in a second. Commercial insurance. It's important that these are young adults, many of whom may be on their parents' insurance program because of the Affordable Care Act, and so commercial insurance has a role to play. As of this date, it plays a very minor role typically, and state and local funds, which are highly variable, also can be used to support the program. Next slide, please. Currently, fee-for-service reimbursement is kind of the dominant theme, so that those 5 services that I highlighted earlier are billed at community rates. Are billed at clinic rates. And as we'll see, those rates are not adequate to cover the services. A team-based rate, and we'll hear from our colleagues in Washington State later, that has developed a team-based rate, covers the full cost of the program and is often paid on a per member per month or encounter basis, but the encounter basis comprising the full cost of the program. And then oftentimes we have braided funding, which means that there's, at this point in time, particularly, there's some funding that comes from insurance coverage and other sources of revenue like state and local and block grant are braided with the insurance coverage to cover the full cost of the program. Now, in the study, next slide, please, we did a series of case studies, and this highlights the states that were featured in our studies. And what we have are a few sort of summary findings that characterize each of the states. Next slide, please. Here you can see the distribution of revenues that's typically earned by programs in New York and Ohio to help support the programs. And this sort of illustrates that notion of braided funding very nicely. And then you can see that state funds, Medicaid funds, block grant funds in New York, as well as some commercial insurance, comprise coverage for the overall program. You can see that the mix is somewhat different in Ohio. Now, this is revenue that's actually earned in current programs, and we'll be talking about, when we talk about New York in a little more detail, the notion is that both New York and Ohio have done studies of the actual cost of delivery of the program, and Medicaid reimbursement, typically for Medicaid eligibles, typically only comprises about 50% of the resources necessary to cover these programs. Next slide, please. Here we talk about New York and Ohio, as I just did, and we characterize them. They're both looking and are close to, we hope, developing a team-based rate, which will be something like a per member per month rate that will cover the full cost of the program in Medicaid, and ultimately, we hope, in commercial insurance. Illinois actually has passed legislation that mandates that commercial insurers cover CSC at the full cost, what's characterized here as a bundled payment. We prefer actually generally to call that a team-based reimbursement rate. And they've moved forward with, at this point in time, Blue Cross Blue Shield and Optum to actually develop that reimbursement mechanism. We'll be hearing from Washington a bit later. My good colleague, Becky, will be telling us about the fact how they've used Medicaid to develop a full team-based rate in Washington State, and they're moving to have statewide coverage for the program. And Texas will illustrate the use of something called in lieu of financing. Next slide, please. So in lieu of services, it's basically a payment mechanism that can be used for in managed care programs as a cost-effective substitute for other services that would be available. I mentioned New York State. You can also have a Medicaid state plan rehab option that can cover these services. The CCBHCs can use mechanisms specific to their funding mechanism to cover the services. And centers of excellence are statewide services that can be provided and funded with Medicaid administrative money that can be used to cover training, program evaluation, fidelity assessment, et cetera, et cetera. And I really recommend that people think about using centers of excellence. Next slide, please. So some other funding mechanisms, EPDST, EPSDT.
Easy for you to say.
Yeah, I was going to say easy for me to say. Can be used for younger clients and can be used as a payment mechanism. And we're talking about team-based billing codes. We'll talk about this a little bit more later with some of our colleagues from CMS. But the Center for Medicaid and Medicare Services just October 1 released 2 team-based codes for coordinated specialty care that are intended to cover the full cost of the program. Finally, one last slide after I did EPSDT so well. So the report conclusions are the availability of CSC has, with the block grant support, seen a substantial growth over the last 3 years. Early psychosis intervention is cost effective. And there goes my timer. States use different strategies to fund CSC by braiding funds to the mental health block grant. We hope ultimately more and more states will move to a team-based service that covers the entirety of the program. Financing strategies for other team-based services highlight options like assertive community treatment, multisystemic therapy, both have a team-based rate. And the recent issuance by CMS of these 2 billing codes for coordinated specialty care, we hope will really enable further insurance reimbursement for these services, which is going to be critical if we're going to reach population coverage. Howard?
Thank you, David. That was a whirlwind tour of the report. I'm glad we're going to make it available to people if they want to take their time to read it or focus on some of the details. This gives us plenty of time, plenty of material as a setup for our panel. We have 6 panelists. I'll introduce them all first, and then I have some lead questions for them to take us through the minutes that we have together. The first speaker is going to be Kirsten Baronio, who's been working on federal policies both inside and outside of government for over 20 years. She had leadership positions in federal agencies and advocacy organizations and in the U.S. Senate. She recently returned to the Center for Medicare and Medicaid Services within the Center for Medicaid and Children's Health Insurance Program Services in particular, where she serves as a senior policy advisor in the Center Director's Office. Her initial remarks on the experience before the development of these HCPCS codes will be followed by an example from Virginia offered by Jeff Van Arnhem. He's the Adult Mental Health Services Manager for the Virginia Department of Behavioral Health and Developmental Disabilities. He's an expert in assertive community treatment, both as a provider and an oversight manager for the state and providing support, to their 41 ACT teams. He took that experience with team-based care and has applied it to the state of Virginia, where they have 11 coordinated specialty care programs, and he has worked with them, providing oversight and direction for the last 6 years. After he tells us a little bit about Virginia's experience in financing coordinated specialty care, we'll hear from Becky Daughtry, who we've already had referenced by Dave Shern. Becky's a licensed clinical social worker. She's had more than 30 years of experience working in community mental health, and she's currently the Washington State Healthcare Authority First Episode Psychosis Program and Policy Manager, almost as easy to say as EPSDT. Becky first became familiar with First Episode work in 2016, and she's brought her creative energies to figuring out new ways to serve the citizens of Washington State. We have 2 more presenters from CMS. We have Cheryl Gilbreth, who's a pharmacist, and she works in the unit at CMS that evaluates the HCPCS codes. That's Healthcare Common Procedural Coding System, the level 2 coding requirements. And we're going to hear from her a few minutes of comments about what that process was like. And our final panelist is Andrew Badaracco, who's the Deputy Division Director for the Division of Reimbursement Policy in the Financial Management Group at the Center for Medicare and Medicaid Services, in particular in the Medicaid and CHIP Services unit. Because David was so good with his time, I got to provide a full introduction to all of our panelists. Now we'll circle back to Kirsten, and she'll tell us a little bit about the history leading up to the HCPCS codes. I'll turn the floor over to Kirsten.
Thank you, Howard. Good morning or afternoon to all of you. I am going to provide a little bit of background on how the Center for Medicaid and CHIP Services has been trying to encourage state Medicaid agencies to support broader implementation of evidence-based programs to address and help address the needs of people with serious mental illness, including through raising awareness about the coordinated specialty care model of care. For years now, we have made a concerted effort at the center around this issue. I think the first that I know of is back in 2015. We actually partnered with SAMHSA and NIMH to develop some guidance, really focused on raising awareness among state Medicaid agencies about the coordinated specialty care model, and really building on the RAISE study that a couple of folks have referenced, and raising awareness about how that study really explored and tested implementation of the CSC model in real life settings, and really going over some of the very important findings from that study, as well as some of the really robust evidence base for this type of team-based intervention. That guidance, which I can put in the chat a link to, also outlined how state agencies should think about financing availability of that type of intervention, including SAMHSA block grant funding, as well as the Medicaid piece, and really going into detail about all of the different Medicaid authorities that state Medicaid agencies could point to support coverage of the different components of the CSC model, including, authorities around paying for other licensed practitioners' services. The rehab option, which David mentioned, is a key part of the coverage piece there. There's case management, few different approaches to covering home and community-based services. So that guidance from 2015 really went into detail around all of those different federal Medicaid authorities that state Medicaid agencies can point to support coverage for the different components, as well as, sort of references to the block grant to kind of fill in some of the gaps. Then in 2018, we issued a state Medicaid director letter, which is the 2015 letter was more of an informational guidance document. The state Medicaid director letter, that's a mechanism we use to really announce very significant policy developments. And that we used that platform in 2018 to really outline and focus on opportunities to design innovative service delivery systems for adults with serious mental illness and children with serious emotional disturbance. The first half of that guidance document is focused on the interventions like CSC and a few other really very strongly evidence-based interventions, and then how those can be actually supported with existing Medicaid authorities. And CSC was highlighted prominently in that letter, which also pointed out there are some of the key challenges around the existing financing mechanisms at that time. So as was mentioned, outreach and engagement is a little bit, there's nothing really directly that can be pointed for authorizing, direct payment for that kind of activity, as well as network and referral systems. Those are some of the gaps that we talked about in that guidance letter. But we also pointed out those kinds of costs can be built into the cost of providing care and provider reimbursement indirectly paid for in that way. But, recognizing that there is sort of a patchwork of different authorities and different payment mechanisms that have to be tapped for really fully supporting this model. And then more recently, I wanted to point out some guidance we issued in January of this year that addressed an issue around interprofessional consultation, which is a key component as well of something like the coordinated specialty care model. It's also, we reference in that guidance, we mostly talk about the collaborative care model, but in both of those kind of models for delivery of care, team-based models, you really do, a key component is being able to access specialists to help address some of the many needs of people with serious mental illness. So I wanted to point out that one as well. We're trying to really tap into all the different authorities we have to try to help support improved access to care for people struggling with these conditions. So with that, I think I'll turn it back over to Howard to, sort of move on to the next panelist.
Thanks a lot, Kirsten. I have to say, from a personal point of view, I was the liaison to what was then the Healthcare Financing Administration for Medicare and Medicaid. When I was assistant director of NIMH, my portfolio was relating to Social Security and Medicare and Medicaid, and we would have loved to have had interlocutors and supporters like you've just described and like you've been for the field. And big shout out to you and to your colleagues for that. We've watched this develop for decades, and we've never had a closer, more productive relationship. We want to hear first, before we come back to some of the details of the use of the HCPCS codes, we wanted to hear from two state experiences. I've already introduced Jeff Van Arnhem. He was going to tell us a little bit about how Virginia has managed to pay for coordinated specialty care in the era before the HCPCS codes were available. Jeff, the floor is yours.
Yes, thank you, Howard, and thank you, everyone. I appreciate the opportunity to be here. I think we can look at Virginia's history with coordinated specialty care, funding coordinated specialty care in 3 stages, a past, a present, and a future. Originally, in 2015, with implementation getting underway, obviously the main source of that was the block grant set aside. We also are fortunate to have some significant state funding delivered for our CSC programs as well. So that combination, in addition to them being the providers, the teams, being able to bill a little bit here and there for things like case management and medication management, peer services, individual group therapy where they can. Those are sort of the 3 things keeping CSC moving forward in Virginia. Fast forward to 2021, a couple years ago, time has flown. ARPA. With the ARPA funds, we put out an RFP and we're able to get 3 of our community services boards, which are our public mental health providers, some seed money, for lack of a better term, to stand up 3 more coordinated specialty care programs, bringing us to the 11 from the original 8. On top of that, with those funds obviously expiring, we were able to tap into the mental health, the base block grant, to have some additional funding go to those programs as well. So now with those 11 teams operating under that structure, in that context, 2 years ago, our General Assembly required or asked our Department of Medical Assistance Services, our State Medicaid Agency, DMAS, to work with our agency, DBHDS, to come up with a 5-year plan for growth and sustainability of CSC. One of the first things that went into that report, and an annual report is due to them, obviously, yearly. First thing that went in there was trying to get a rate study done. We have been very successful few years back with a different initiative in the area of team-based intensive community-based services with ACT and MST and FFT. So we, Dave, you got me. Mine are only 3. However, we weren't granted the authority or the funding that go around to move forward with the rate study, but that will be back again in front of the General Assembly from us as a recommendation in our next report. And so that's sort of where we're heading. That's the next incarnation of our funding moving forward at this point.
Thanks, Jeff.
Thank you.
We'll turn our attention to Washington State, clear across the country in the shadow of Mount Rainier behind Becky. You want to tell us a little bit about your experience in funding CSC, using block grant funds to establish the new teams, but then to use Medicaid to have a team-based rate for CSC. You want to give us sort of the dope on how you managed that?
Thank you, Howard. Good morning from Washington State. The coordinated specialty care in Washington is called New Journeys. And initially, Washington developed New Journeys coordinated specialty care pilot sites with the support of mental health block grant set-aside funding in 2015. And then the Children, Youth, and Family Behavioral Health Work Group advocated for a second substitute Senate Bill 5903. This legislation required the statewide expansion of coordinated specialty care based on incidence and population and the development of a Medicaid financing strategy. So the New Journeys team-based rate was launched into Medicaid in 2022. It was developed through an actuarial analysis of the service utilization data of the pilot coordinated specialty care teams here in Washington. It included unique team-based costs and is reimbursed through a monthly, through MCOs, and includes a per member per month service-based enhancement that is not a directed payment. Since launching the team-based rate, we've been able to transition 7 New Journeys teams from mental health block grant support, freeing up funding for startup costs to launch more teams statewide. Provider feedback indicated the need for further support, and Washington again partnered with Mercer and TriWest actuarial groups to develop an additional encounter rate to be used in conjunction with the team-based rate. The encounter rate was developed to address gaps in the team-based rate by expanding coverage to those falling outside a 24-month benefit eligibility period, and also to provide more flexibility for variable caseloads and service utilization, as well as capturing the true costs of services, especially salaries and travel. The updated financing will help expand Medicaid funding to cover team costs more fully and further support ramp down of the use of mental health block grant funding to support the teams. We hope to free up to implement the encounter rate July 1st of 2024, which will free up future funding for model adaptations to focus on communities in Washington that are at risk of being underserved.
Great, thanks for that overview. Now we're going to go back to the process of creating HCPCS codes 2040 and 2041. And Cheryl Gilbreth had agreed that she would tell us a little bit about the process of approving those codes for use in the Medicaid program, both the initial application and the responses. You want to take us a little bit through that process, Cheryl?
Yes, thank you, Howard. So many of you may be familiar with the current procedural terminology or CPT coding system. That's maintained by the American Medical Association. And it's a numeric coding system, and it's used primarily to identify medical services and procedures furnished by physicians. and other healthcare professionals. On the other hand, the HCPCS Level 2 codes are maintained by CMS and are used primarily to identify drugs, non-drug items, supplies, equipment, and services that are not included in the CPT code set. Because insurers cover a variety of services that are not identified by the CPT codes, then a HCPCS code could possibly be established. So anyone may submit a request for a HCPCS code online via the Medicare Electronic Application Request Information System, better known as MIRIS. And in the case for coordinated specialty care, the National Association of State Mental Health Programs submitted a formal request, and they included descriptive literature to help further the HCPCS team's understanding of the clinical features and need for this requested code. So the overall application review was a 9-month process with some milestones. First, the application was received on or before the first business day of January 2023. And we reviewed internally and published our preliminary decision in May, stating we were open to feedback on whether there was any overlap with the existing CPT or HCPCS codes and how insurers, especially the individual state Medicaid agencies, would approach a unique HCPCS code that was requested to identify CSC. During our public meeting in June, the interested parties were given an opportunity to make oral presentations and submit written comments in response to our preliminary decision and questions. And that definitely helped formulate our final decision. 4 major things from the commenters stated that a unique HCPCS code to identify CSC would, 1, create a streamlined billing experience used by multidisciplinary clinics and insurers to identify CSC in claims. 2, facilitate research and measure the long-term outcomes of CSC in larger databases across various payers. 3, commenters also stated that while existing codes could be billed for psychotherapy and medication management, these existing codes do not capture the other non-clinical services offered by the CSC team, such as education and employment support. And finally, commenters suggested that 2 HCPCS codes be created to describe both the monthly and individual encounters, because this would allow greater flexibility in application of the various insurance billing policies, and as well as provide transparency for the integrity of all the claims data. So as David mentioned in the slides, in August, we announced our final decision to create 2 HCPCS codes, H2040 and H2041. Back to you, Howard.
Thank you for walking us through that arcane process that few of us get any kind of a glimpse of, but it's just not possible to overstate how important this has been for the field. The block grant set aside and supplement gave us the resources in every state to start programs, but it just was not adequate as a sustainable source of financing. So now that we have these codes, though, the job isn't done. And that's why we've invited Andrew Badaracco to tell us a little bit more. So now that those codes are available for use in Medicaid, what has to happen? Can you tell us more about the process and in detail, a little more granular approach?
Absolutely. And I'll say that David's slide covered quite a bit of in terms of Medicaid rate setting, but to put a finer point on it, in Medicaid, we pay for allowable Medicaid services provided to Medicaid enrolled individuals by Medicaid enrolled providers. And so that means that every component of services that are provided, whether it's in a bundled payment or on an individual basis, have to be covered by the state under their state plan. We cover those services as they're laid out in the state plan, and there are some optional and some mandatory services under the Medicaid state plan. However, to kind of piggyback off of what Jeff was saying about their rate analysis in Virginia, states have a number of options and flexibilities when it comes to setting their Medicaid fee-for-service payment rates. One option would be to conduct a rate study to look at what it costs a provider to operate a program such as CSC, and make a determination about expected levels of care, expected levels of effort, and provider salaries, and look at how those translate into the unit of service that the state wants to recognize, whether it's a 15-minute unit, an hourly unit, a day, a week, in some capacity. Then they would go about figuring out what that looks like statewide. If they did a rate analysis at a state, for one provider in the state, they would look at and smooth that out across the whole state and come up with rates that would be applicable for those providers. There's no requirement that states undertake that effort. They can use cost reports. They can use everything up to other states' reimbursement rates for rate setting efforts. If a state was interested in starting this process right now, they could look at existing state programs and say, okay, state A pays these rates. I'd like to pay these rates based on some geographical differences, and apply those factors, and then come in to go to the state Medicaid agency, and then state Medicaid agency would come to Medicaid and raise those rates and say, this is what we'd like to pay for these particular services. Though that methodology would be placed in the state plan, and CMS and the states would work together to make sure that methodology got approved. As David pointed out, states have a number of options for reimbursing services. They don't necessarily have to follow bundled payments where they exist in other programs. They can use fee-for-service as the state desires. They can also follow team-based bundled payment methodologies. But as I said at the start, all of the services in that bundle need to be coverable under the Medicaid state plan. That's a really big component for Medicaid. And then further, when we pay for Medicaid services, if you are going to pay as a bundle, the recognition of that payment of that bundle is the payment for services. So for any team-based approach, and we would have advised any states to come to CMS with this question, is you really have to pick a primary point of contact or billing provider for the team. And so once payments made to the team lead, I'll say for lack of a better word, the team lead then distributes the payments to the rest of the providers in the team. That way we're not making multiple payments for a single Medicaid service under the state plan. It's just a very complicated process, and there are regulations and provisions in statute that address directed payments to providers. Finally, the last piece that we would look at in terms of Medicaid rate setting is financing. States have a number of options at their disposal, all of which are outlined in statute. And in short, they are state appropriations to the Medicaid agency or a provider tax, intergovernmental transfers, which are transfers of funds from units of government, of state or local government, and finally, certified public expenditures, which is a reconciled cost process by which a unit of state or local government certifies their expenses for what they paid to provide services. Now, there are lots of options within each of those three funding mechanisms, and any of the reimbursement methodologies that a state might want to follow. And CMCS is open and ready to discuss any options the state wants to pursue when it comes to one of those rate setting methods. So with that, I'll turn it back over to Howard.
That's great. Thanks, Andrew. That's really, really helpful. Just to clarify, is the first step that every state needs to initiate this process a state plan amendment?
Yeah, I think that's probably halfway through the process. I think as Jeff's experience bears out, which is the state should work with and figure out how they plan to enroll providers and implement this program within their states. Most likely, it would likely require some action by the state legislature. As again, just going to harken back to Jeff's experience because it's happening in real time. They would go to their state legislatures, work out what that looks like, if there are any changes to their state law and provider licensure processes and things like that, even up to and including earmarking funds specifically for this activity in their budget bills. So yes, I think as far as CMS engagement is concerned, likely the first step would be coming in with state plan amendments, but we talk with states all the time about proposed plans that they have or draft agreements or things that they want to consider pursuing. And we're certainly open to that.
Great. And just to underscore the importance of the HCPCS codes, it's what in medicine is referred to as a rate limiting step. Without that change, we really couldn't have gotten the process going, but it requires additional work, both background work and some work with your Medicaid office in every state to amend the state plan. Well, our timing worked. We're right on schedule for questions and answers. Everybody's been really outstanding. It was good that we got together and we figured out the right flow and everybody stuck to their plan. So I'm going to turn it over to Jennifer Caputo for the question and answering period here. I earlier introduced her as the Westat task lead, and she's going to handle the questions. I guess we got quite a number during the process, and we had some that had been developed before. Jennifer, the floor is yours.
Yeah, so
take care of
thank you, Howard.
Thank
you, Howard, and thanks to everyone who's been submitting their questions in the Q&A. It looks like we've got about 5 minutes to make our way through some of those that have yet to be answered, and feel free to continue to add questions. We'll reach out after the webinar to provide answers to any of those that we don't get through. And we also have some questions that people submitted when they registered. But I'll just start with one from Stephen Detweiler, who also was a contributor to this report. And he asks the panelists whether CMS has data on the uptake of HCPCS codes by state plans, and if these new CSC HCPCS codes are being used by providers, or is it too soon to have some of these data?
Well, I would just say that the HCPCS codes were just made effective October 1 of this year. So not even 30 days of, pretty much this is the 30th day. So that's all I can say about the timing.
29 days, what are you waiting for?
Okay, and we have another question that just popped up from an anonymous attendee. How do we know if our state has a bill or law passed that mandates insurers cover coordinated specialty care, similar to Illinois' law? Is there any sort of helpful resource that any of you know of that a person could use to look this up?
Not that I'm aware of off the top of my head. It's Virginia, as Jess said, is in the process of developing a plan. Massachusetts has submitted legislation around commercial payment, requiring commercial payment. But there's tremendous variability between the states. And I don't know if the question was specifically with regard to commercial insurance or just more generally.
Wouldn't the state insurance commission be a source? I mean, most people would be interested in what their state requires or doesn't require. And I believe the State Health Insurance Commission is a source to answer that question.
Good, Aaron.
Okay, we have another question from an anonymous attendee. You mentioned Medicaid reimbursement. Can panelists provide guidance on how to reimburse for individuals that do not qualify for Medicaid yet meet eligibility for coordinated specialty care?
That's a great question. And I think, Becky, I don't want to put you on the spot, but I mean, Washington's reimbursement model includes funds, state funds for people who are uninsured. Becky, do you want to sort of fill that in, if that's okay?
Sure, David. The state of Washington provides state funds through regional BHASO contracts to fund slots for unfunded people that aren't covered by Medicaid or are underinsured through their commercial carrier.
Probably also worth saying that there are a lot of people who are eligible for Medicaid that are not enrolled in Medicaid, particularly through the Affordable Care Act and a change in the requirements. People no longer have to be disabled, which was for many, many years, maybe decades, an impediment to states actually developing first episode psychosis programs, because most public mental health systems are funded by Medicaid, and the way you got on Medicaid before the ACA was beyond SSI. So this has really been a confluence of important progressive policy changes that make Medicaid more broadly available to people on the basis of low income. I guess we have one more question, right?
Yeah, I was going to add, Howard, part of the assertive case management that is a part of the coordinated specialty care model really aims at helping people to find the coverage that they're available to get and get people enrolled. So
Here.
Okay, so unfortunately, it looks like that's our time for the Q&A session. But again, if you have other questions that you want to add to the chat, we'll reach out to you after the webinar session. And Howard, I'll turn it back over to you.
Great. Thanks a lot, Jennifer. I hope that this has been a useful set of presentations, each one very economical, but organized. Our closing remarks come from Thiessen Thomas, who serves as Deputy Director for the Center for Mental Health Services at SAMHSA. He has a lot of responsibility. He works with Anita Everett very closely. He recently was promoted into this position. Before, he was the guy that oversaw the block grants and all of those access to service dollars that fueled the rise of coordinated specialty care. It's been a pleasure working with him on CFRI more broadly on a number of the tasks, and I'll turn the floor over to Thiessen for our closing remarks.
Thank you, Howard, and good afternoon and good morning to some of you. I would like to express our heartfelt gratitude for the exceptional discussion we have had today regarding the financing of First Episode Psychosis program. As a nation, it is imperative for us to take the lead in addressing mental illness, particularly in its early stages. SAMHSA has diligently collaborated with our federal partners to prioritize the financing of this vital program. Our discussion has shed light on the report that SAMHSA recently produced, including examples from few states. We also discussed the HCPCS scores associated with the FEP program or the CSE model, highlighting the federal government's unwavering commitment to advancing these initiatives nationwide. Since 2014, SAMHSA has been supporting the First Episode Psychosis programs throughout the country. As David shared and Anita mentioned in the very beginning, that from a handful of First Episode Psychosis programs for more than 400 First Episode Psychosis programs across the country, it's definitely a project where we scaled up the science to practice. So these programs stand as a testament of our collective dedication to tackling mental health challenges at their earliest stages. SAMHSA's vision is for states to utilize mental health block grant funds for initiating these programs, and once established, incorporate them into their state Medicaid plans to access Medicaid funding. As Kristen mentioned in her opening remarks, CMS has previously sent a whole host of Dear Medicaid letters to states, and these Dear Medicaid letters have provided a lot of information related to the different approaches states can take to make the programs sustainable. We are also pleased to announce the establishment of a new Technical Assistance Center by SAMHSA, aimed at supporting states and programs in various aspects related to First Episode Psychosis. This TS Center's scope extends beyond FEP programs to also include clinical high-risk for psychosis programs. The creation of this center underlines SAMHSA's dedication to providing comprehensive support, guidance, and resources for programs dealing with the early stage psychosis and also clinical high-risk clinical high-risk cases. We are fully committed to ensuring that those who need assistance receive it promptly and effectively. SAMHSA also wholeheartedly committed in collaborating with states to enhance and improve the existing coordinated specialty care programs, while also providing support for future programs. One of our paramount concern is the fidelity of these programs. To maintain and improve program quality, we strongly encourage states to adhere to the CSE guidelines provided by NIMH and ensure that these programs maintain fidelity. There are various fidelity tools available to assist in this endeavor, and SAMHSA stands ready to support states in achieving this goal. In addition, I wish to extend our sincere appreciation to our federal partners, CMS, NIMH, the Assistant Secretary for Planning and Evaluation, and others for their collective effort in supporting the FEP program and the CSE model throughout various means. Their collaboration and shared commitment are vital in achieving our goals. And a special thanks to our dedicated SAMHSA staff, who has been instrumental in overseeing and monitoring these programs throughout these years, ensuring that they meet their intended objectives and positively impact individuals and communities. I would also like to acknowledge Vestat, our technical assistance contractor, for their significant contributions to the development of this report and the coordination of this webinar, especially Dr. Howard Gorman, David Chan, Shoma Ghosh, and Jennifer Caputo. Their expertise and dedication have played a crucial role in bringing this discussion in fruition, and we are grateful for their unwavering support. A special shout out goes to Asha Stanley, the SAMHSA Mental Health Program Coordinator, for her exceptional work in coordinating this event. Last but not least, we want to express our gratitude to all of you for joining us today. It is your work in the field that make it possible for families and individuals facing a first episode psychosis to receive the support and care they need. Your unwavering commitment and dedication to improving the lives of those affected by mental illness are truly commendable. Knowing that these programs are serving individuals and families well is not only gratifying, but also a testament to your dedication and hard work. Once again, we thank you for your vital contributions, and we look forward to continuing this essential work together. Hope you all have a great rest of the day. Thank you. Back to you, Gorman.
Thank you, Thiessen Thomas. It's all about collaboration. You've illustrated that. Farewell to everybody. Look forward to future webinars. Thanks to SAMHSA for the support for CFRI, to the National Council for hosting this webinar, and to all my colleagues all around this wonderful country. Take care.